Hey folks, Ryan here, and welcome back to the Reading Room, this series where I go through common cases in small animal practice to help you level up your radiology game, and I'm super excited for this week's case. I'm talking about new research on 360 GDVs. So this is the case that we gave in the Weekend Rounds newsletter a couple weeks ago and asked our readers to decide, what do they think is going on in this? And as I'm sure you can guess based on the title of this presentation, the answer is actually quite surprising. So our readers actually took a look, and this was a really challenging one, as we can see. So GDV, which is actually the correct answer in this instance, which a little bit tricky, I fully admit, got the least number of votes. Only a couple people said GDV. And then from there, small intestinal mechanical obstruction had the largest number of folks. A couple people said food bloat. A couple people are looking at hypoadrenocorticism. But really, let's dig into this. Let's figure out why this shouldn't be considered a small intestinal obstruction, even if you don't get to GDV. And what are the features of this case that had me thinking about 360-degree gastric dilatation and volvulus in this example. So these are the same images. So we've got our lateral projection and then the VD, which wasn't provided in the email. In our lateral projection, there's a few main things that made me think about 360-degree GDV. The first is that the stomach is quite distended. It's got a bunch of heterogeneous material within it, but then also a gas cap positioned here. This is a left lateral projection, and actually there's no displacement of any of the structures. We certainly can't tell if there's compartmentalization in the left lateral only, but there's nothing screaming GDV or classic GDV from that gastric positioning alone. A couple things I am noticing though is that the esophagus is dilated with gas present here. So you've got the dorsal esophageal border here, the ventral border here, and we've got our nasogastric tube extending through it. And then the small intestine is relatively empty in this patient. There's not a lot of material in the small intestine. So that in and of itself should tell us that this is not a small intestinal mechanical obstruction, right? If we have small intestinal obstruction, we should have at least some distended segments. We've talked about some of those in recent cases. So you can go back and watch some of the older Reading Room videos looking at some examples of mechanical obstruction. And we notice that there are always evidence of some distension of intestinal segments, whether it's just the segment with the foreign body in it, or whether or not there are, larger populations compared to the smaller ones. In this instance, we really have some pretty empty small intestinal tract. The other kind of interesting thing about this case is that this structure here in the mid-abdomen, this is actually the spleen. And that's not the correct position for the spleen. Remember, the spleen should typically be positioned in the ventral abdomen here. So it is dorsally displaced and a little bit caudally displaced. The dorsal extremity of the spleen oftentimes hugs the left caudal lateral margin of the stomach quite nicely and tightly. And here even I'm seeing it displaced caudally a little bit and then extending over towards midline here. So this is some really atypical splenic positioning as well. That all of a sudden is also triggering me to think about GDV in this instance. This is an image that I kind of spliced together. These are two lateral projections. These are the right laterals. And this is essentially showing the same thing. Empty small intestine, gastric distension, and esophageal distension. And so you might be wondering, how did we get to this answer and how were we able to be confident in saying that this is most likely a GDV? Well, this is all coming from recent research that I was a part of. So this was done at our institution, and it was actually a multi-institutional study where we partnered with a couple other institutions to look at the radiographic features of 360-degree GDVs. This was done by another radiologist, colleague of mine, and a graduate student at the time, Dr. Espinosa-Mur. And what we ended up finding was that, ultimately there was actually pretty low sensitivity and specificity among 3 radiologists looking for GDVs. We only had, almost 50% essentially sensitivity, and then specificity got pretty high in this instance, but pretty low sensitivity for actually finding these. But when we looked at the cases as a whole, what we were able to pull out is that severe esophageal distension and an absence of small intestinal distension were the only features that were consistent with or associated with 360-degree GDVs. So now when I'm looking at cases that have an unexplained gastric distension, then I'm looking for those other features to try and tell me whether or not this is actually 360-degree rotated. Because if that's 360-degree rotated, obviously that's a very different outcome than a patient that just has a general bloat or a food bloat. So we've got a couple images that I can show you from the study. This is another example of a 360-degree GDV. We can see the esophageal distension similar to ours. The gastric distension is more pronounced here, maybe in part because they don't have an NG tube in place to decompress that stomach. And here we're showing the location of the pylorus in the correct location in the right cranial abdomen, which is now what we would see in our classic GDVs, which are typically 180 to 270 degrees. Those have that compartmentalization that we're used to looking at. So I hope this has been helpful for you and got you thinking about, some of those atypical findings of those diseases that we sometimes see in small animal practice. GDVs we see all the time. Sometimes we're left with the question of whether or not it's an atypical GDV though, and that would be one of these 360-degree rotations. And this paper I think can be helpful for us to start to distinguish some of those from other causes of gastric distension that don't involve a volvulus. So really hopeful that this will help level up some of the radiology game in practice, and I look forward to coming back at you next week with another cool case.